we're going to be talking about protecting the whole community during a global pandemic, which obviously a very, very timely topic and discussion. This is going to be moderated by Ron Prater, the Executive Director for Big City Emergency Managers. Ron, I'm going to turn it over to you to let you talk about the panel and give an introduction and then take it from there. And Ron, I will say that did reach out to me earlier. I think he may be having some technical issues with regards to his camera. If that's the case, then he will be off camera, but hopefully get his voice. And if for some reason that's a challenge, then I will step in and do my best to moderate the panel. So Ron, are you with us? Okay, I see the panelists coming on, which is great. I see Chris and Julie.
Hey, Vance, this is Ron Prater. Can you hear me?
Okay, I can hear you now, yeah.
Okay. All right, so I dialed in the phone as well, so I don't know which one's picking up, but I'll do my best. I'm having a lot of Wi-Fi issues.
Okay, great. Just so you know, we've got Chris, Julie,
Yep.
and Grady all have their cameras on.
Excellent, excellent. And I've been emailing with Roxy, so I think she should be on any second.
And she just turned her
Here she
camera
comes.
on as well. All right, with that, I'm going to back out and leave it to your panel.
All right, well, Vance, like I said, jump in for me. I apologize for my Wi-Fi issues, everybody. Thank you, Vance, and I'm very honored to be here helping out today with this important symposium. Good afternoon to all of you, and to some of you, good morning for those of you on the East Coast or West Coast. I'm excited to have the opportunity to moderate this panel, Protecting the Whole Community During a Global Pandemic. Once again, my name is Ron Prater, and I'm the Executive Director of a small not-for-profit called Big City Emergency Managers, or BCEM. We're a small group made up of emergency managers from 15 of the largest jurisdictions in the country. I'm incredibly fortunate to get to learn from emergency managers from across the country on almost a daily basis. And fortunate for you, you won't hear from me a ton today. You'll get to hear from these great panelists. On this panel, you'll get to hear from those across all levels, local, state, federal government, as well as the private sector. I describe myself as, well, old, very little brown, gray hair, brown eyes, and middle build. My pronouns are he, him, and his. To say that the last few years have been trying times is an understatement, especially when you talk to
Yes, I'm sorry, I can hear. I can hear you.
Oh, there you are.
Just
Can you all, hey, thumbs up if you can hear me. Can you all hear me okay? Okay, good, thank you. I appreciate that, panel, for thumbs up. I appreciate that. Where was I? Oh, I really hope you take the time to listen to the panelists' experiences today, their lessons learned, and advice for the future. While we are going to talk primarily about pandemic planning and response, I have no doubt some of the thought processes will apply to other disasters like hurricanes, earthquakes, and wildfire response and recovery. I'm sure that an important takeaway will be that we as a society need to better integrate the AFN community into our planning efforts. And there are those around the country, like my good friend Vance Taylor, who are making this happen. For any of you that heard Vance's opening elevator story, you know that he has way too many examples like that story. We need to, as a community, work to minimize these stories and to better understand all perspectives. To start, I'm going to ask each panelist to say a few words about her or his background. After we do these brief introductions, we'll then jump into the discussions. Panelists, don't forget to turn your video and audio on as you speak, and then turn off your video when you are done. Roxy Crawford, representing the Federal Emergency Management Agency. I'll start with you. Can you give a minute or two about yourself?
Sure. Thank you, Ron. Hi, I'm Roxann Crawford, Roxy, and I work in FEMA Region 9 as the Disability Integration Specialist. I've been with FEMA for about 17 years, and I've been in the Region 9 office as the Disability Integration Specialist for about 6 years. FEMA Region 9 covers the states of California, Arizona, Nevada, and Hawaii, and all of the Pacific territories. So I've been partnering with Vance Taylor's office at Cal OES for the entirety of my time in the region, and we worked very closely together on the vaccination mission. So I'm super excited to get to talk about some of those experiences today, the good, the bad, the ugly, all of it. And so happy to be here. I'll pass it back to Ron. Thank you.
Thank you, Roxy. Grady Joseph, representing the California Office of Emergency Services. You're next.
Good morning, everyone. My name is Grady Joseph. I'm the Assistant Director for Logistics Management here at Cal OES. Began my emergency management career at FEMA headquarters in Washington, D.C. in about 2011. Had the opportunity to work on some important programs there, really trying to reach disadvantaged communities, the biggest one being the Disaster Survivor Assistance Program. And so we stood that up after Hurricane Sandy with the explicit purpose of meeting people where they were. And that's really been a theme throughout my emergency management career. From there, I went to FEMA Region 9, and then in 2019, I had the opportunity to come home to California and work in the recovery operations section for Cal OES during the COVID-19 pandemic. I was tasked to help coordinate logistics, which brought me to my current role. So AFN is a huge part of what we do in partnership with Vance and his team, and I'm really excited to be here today and talk more with all of you all about it. Thanks.
Thank you, Grady, and excited to hear about your various experiences given the different angles you have. I can't tell if we dropped Dr. Rodriguez or not. Chris is also on my big city emergency managers board, and he's the director of Washington, D.C.'s Homeland Security and Emergency Management Agency. Chris, can you introduce yourself? Are you still with us? All right, Chris may have.
No.
Here he comes.
Hey, Ron,
I
apologize. Good afternoon,
okay.
everyone. Apologies. Yes, my name is Chris Rodriguez. I'm the director of the DC Homeland Security and Emergency Management Agency. It's a privilege to be on this panel talking about some very important issues today. I hope to have a very fruitful discussion about some of the things we're doing in Washington and get some feedback from a lot of the experts on the line. So thank you, Ron, and look forward to the conversation.
Heather, can you call?
Thank you, Chris. And Julie, the Executive Director of the Colorado Cross Disability Coalition, can you please wrap up our introductions for us?
Hi, everyone. My name is Julie Reiskin. I'm with the Colorado Cross Disability Coalition, and we are a statewide social justice organization representing people with all types of disabilities, which is what cross disability means. I am not an emergency response or management professional, but as a social justice organization representing people with disabilities, we obviously got very involved with the pandemic response, as we have in the past when there's been an emergency in Colorado that's been mostly wildfires and mass shootings. So I'm the non-professional on this group that can talk about how to involve community with, when you're making decisions. So thank you. I'm happy to be here.
Thank you, Julie. And I'm proud to say I think we have a whole community group here, so we have great discussions. And thank you, panelists, ahead of time for your participation today. For the audience purposes, our intent is to cover the challenges and some solutions to the large vaccine sites that were set up, mobile vaccines and PPE distributions. There's a lot to cover, so hopefully we can get through a good portion of this. We'll do our best. Let's get going now. So panelists, starting with the federal perspective and then going to the state, local, and then to Julie, the private sector side, can you please discuss some of the challenges you observed during the pandemic in protecting the whole community? Let's start specifically with the large vaccine sites. And Roxy, we're going to start with you.
Okay.
Roxy,
Hey.
there you go. Perfect.
Hey. So, I mean, there's, like you said, there's so much to unpack here. The mega vaccination sites were just that. They were mega. They were quite large. And there was a number of challenges when establishing the mega vaccination sites. beginning with the actual selection of the sites and trying to ensure that what is accessible now as a parking lot or a parking structure or just a large empty building, what's accessible now stays accessible after the build out of the site. So that's everything from ordering and planning for accessibility, physically, communication-wise, and programmatically, working with our logistics team, working with the state and county level individuals to make sure that the way that we were building things took whole community and accessibility in mind. There's of course the real focus on whole community, and that we couldn't just have a drive-through site or have a site that's just in one area of the city. The sites needed to be accessible to everyone, including people without personal vehicles, people who don't drive due to having a disability or for whatever reason, people who take public transportation or have to use rideshare or paratransit or walk. We also really needed to put effort into thinking about the communities that we were putting the sites in and consider those who have historically had less access to programs and services in general. Those whose communities might not be able to get to other areas of a huge city like Los Angeles or Oakland, or who may be more comfortable receiving services through a trusted partner or trusted service provider than going on their own to a large facility. So in addressing all of those challenges, as the FEMA Disability Integration Advisor for the Los Angeles site and supporting the Disability Integration Advisor lead at the Oakland site, our roles were specifically to support the state's efforts in helping to coordinate those fully accessible vaccination sites. And then also took into consideration what's necessary to serve a diverse population and reach that whole community. So we worked closely with Vance's team to consider, specifically, I'll just start with one thing, physical accessibility. And that physical accessibility, as I mentioned before, is more than just being able to provide services at a long drive-through site where individuals would stay in their personal vehicle. We did need to have a pedestrian site available for individuals who needed to be dropped off or who took public transportation there, specifically paratransit, and working to prioritize that mode of transportation. We worked directly with the paratransit companies to coordinate schedules. So they would be able to have the vaccinator board the bus or provide services to the individual on the van or the vehicle that they rode there in. And they were able to remain in the vehicle, which negated them having to coordinate or schedule a return visit, which could leave that individual sitting there for who knows how long, based on how long it took to receive the vaccine. So we worked with them to receive a schedule daily as to what times individuals had scheduled rides for and be able to provide that prioritized service to the individuals on site. If someone arrived at the pedestrian site and they weren't able or weren't comfortable going inside, we worked hard with the teams that were there to be able to provide services in a way that allowed people to self-determine how they wanted to receive a vaccination. So they could receive a vaccination at their actual vehicle. We did consider public transportation and ease of access. So specifically in Los Angeles, I'll give an example. The walk from the bus and the metro stop, it wasn't super far, but it was still maybe 2 blocks. So it was far enough given the California weather, not exactly sure what you're going to get on any given day, that we worked with Vance and his team to coordinate the shuttles and made sure that the shuttles were accessible to take people from the bus metro stop the couple blocks over to the pedestrian vaccination site so that they would be able to receive their vaccines and not have to walk in super hot or rain, depending on what it was. And those just ran a loop. So they were constantly going to and from. The pedestrian sites were there for people who maybe needed additional assistance or time, people who weren't comfortable receiving a vaccine in a vehicle, those who have reaction to medication or known allergies, just individuals whose preference was not to be getting a vaccination in their vehicle, those who came there with an Uber or a taxi, which maybe is cost prohibitive if you have to take it through a line that potentially has a long wait. We had to think about things also with the drive-through as well, ensuring that there were accessible restrooms along the vehicle route and pedestrian sites, so that individuals would be able to use the restroom if the line got super long. And that includes accessible hand wash stations, which oftentimes get missed, manual wheelchairs, and being able to assist individuals. If someone was in the drive-through lane and they did end up needing to use the restroom and they weren't able to access their own mobility devices, or they needed some assistance in getting to the restroom or the accessible restroom, we did have manual wheelchairs on site in both the drive site and the pedestrian site to be able to provide individuals that assistance, and making sure that people knew that they could ask for assistance. We had signs everywhere that said, just ask, what do you need? You know, we will do our absolute best to provide services and meet you where you're at, to make sure that this is a positive experience for you. Registration tables, when individuals came in, if they were identified as needing language assistance, we did have communication access on site in terms of interpreters. So Vance's office did an incredible job of looking at the demographics and taking intel and coordinating, deciding what languages would be available on site. There were at least 7 languages in Los Angeles and at least 7 languages available on site in Oakland, including ASL. And again, those were chosen based on demographics and local intel. And those interpreters were invaluable to the process. But thinking about how to utilize them best and making sure that they were available to individuals at every step of the way just required a little bit of creative thinking and teamwork in where they were posted, sitting, and how they were identified. So we did provide them with vests that had the language that they were interpreting, and we had a system where we would put something onto like a big laminated paper onto the windshield so that it was known for the vaccinator to radio for the interpreter to come to whatever lane. So as the individuals were coming into a drive lane specifically, as they were getting sorted to the lane, they would radio which lane and what language was needed so that individuals would receive the vaccination in a way that was truly accessible to them. They had an opportunity to ask questions and to receive that information in their language. And we also had the same languages posted over at the pedestrian site, both Oakland and Los Angeles. And when we'll talk more about mobile sites later, but we did also have interpreters available at the mobile sites as well. Language needs were also available if we didn't have that particular language on site. We did have a language line on the telephone where people could call in, and we would have the phone or the iPad utilized for that service, and had the individual would go through the route and be able to use the language line to access services in their language. Specifically programmatic, this gets missed a lot, and that is how we work with our own individuals to make sure that we understand how to provide services, that we understand how to work with people with disabilities and what we might need to do. So training of staff and availability of disability integration advisors to assist with immediate questions and needs, issues, mobile site inspections, every single one, and changes in operations, because let's face it, things change on the daily, and those immediate needs issues that would pop up were pretty big. We at the California sites and the Arizona mobile routes in Tucson and both the Nevada mobile rural routes provided training to every single person who worked in any capacity at those vaccination sites. And again, we encountered all kinds of challenges on the daily, and worked with the state and the county level coordinators to address those immediate needs. So, I mean, that's kind of in a nutshell. There's still a lot more challenges that were faced in things, but I will pass it on back to Ron and let him see if other people have things to put in. Thank you.
Roxy, thank you. That was excellent. I'm going to jump to Grady now, continue along the large vaccine sites. And what did you all do and what did you all learn?
Yeah, absolutely. Roxy did a great job of covering many of the different components, but I think it's important for us to kind of zoom out a little bit and talk first about how these sites came to be. So like any good emergency management initiative, we got a phone call about 12 p.m. on a Friday before a long weekend, and the Biden administration was interested in doing some large scale vaccination sites. And so, California was tasked with partnering with FEMA Region 9 and FEMA headquarters to stand these up. And so from the time that we were, asked to begin looking at this to the time that these were operational, at least initially operational, was a little over 2 weeks. And so the target for these sites was to vaccinate at least 6,000 people per day. Both Los Angeles and Oakland at several points during their mission and during their open times exceeded 10,000 people per day. In total, we vaccinated over 800,000 Californians during the time that these were open and operational. And, AFN and integrating Roxy team and Vance's team was critical from the very beginning, because we were the entire mission here was to bring large-scale vaccination programs to communities who were disproportionately impacted. So we were looking for high access and functional needs communities, minority communities, and just overall generally trying to approach this from an equity perspective, because we knew that most other places in California with means we're going to be able to access these. And so making sure that we had Roxy's team tightly paired in with my folks and the logistics staff as we were building these things, from understanding the need to work with the local transit organizations at both Los Angeles and Oakland. We had dedicated bus routes that were specifically for going directly to the vaccination sites to cut down on that transit time for folks who are coming from further out areas. As Roxy spoke about, we realized early on we had stood up these, primarily we knew that we were going to get the throughput through the drive-ins, but Ubers and Lyfts became something that we had to quickly kind of mitigate through. It wasn't feasible for those folks to sit through a 30-minute line. And so, we created diversion lanes that included paratransit, so that, it wasn't, get in, get out type of situation, but we had areas designated for vehicles to stand and wait for the folks who were arriving via those modes of transportation to be able to get vaccinated, then leave, so they didn't have to call another paratransit service to be able to come pick them up, waiting hours for that entire transaction to take place. The wayfinding from the BART station or the metro station in Los Angeles was incredibly important. And I think just making sure that everybody on the staff, from the operations section, the logistics section, the planning section, knows that this is an iterative process as we're doing new things and missions that are not our normal day-to-day that we do during fires or something like that. We're going to catch things, we're not going to get it right up front, but having the entire organization, and these were very large operations, about 1,200 staff working at any given time for each of these sites to be able to support the mission. Just making sure that if you see something that's not working for a particular community, to raise that up and highlight that quickly so that we can address it and make adjustments as we're seeing those issues arise, and constantly getting better. So I think by no means were we perfect when we stood it up. But just the entire organization was very deeply oriented around getting better every single day, and making sure that as soon as we catch an issue that we maybe didn't think of, we were finding solutions to be able to adjust that. That also came back to the technology as well. We had stood up California, a new platform under the public health department to sign up for vaccinations. And initially when that went live, we didn't have any way for us to understand what clients were coming to us in any given day. And when you have 10,000 appointments, that can be pretty tricky. And so working with the technology teams to make sure that we had buttons added into the sign up and registration process to be able to let us know as we were receiving who was going to have a language need, what language was that, access and functional needs, so that we could prepare for folks to come in at these specific times and have resources waiting for them and be able to anticipate needs as best as we possibly could. So, I think overall, it was a great success. I know we'll get into mobile and we'll get into some other parts in just a minute, but I really think that the core for us is just having that tight integration early and having all the teams, just mission focused on improving and making sure that we're getting better and catching items and addressing them very, very rapidly is the way that, we try to make sure that we set everybody up for success.
Grady, thank you. All right, now I'm going to jump over to Dr. Chris Rodriguez, the director of HSEMA in Washington, D.C. Chris, can you talk some about your challenges and lessons learned based on large vaccine sites?
Yeah, thanks, Ron. And I appreciate, everything that the other panelists had talked about because, here in Washington, D.C., we experienced similar challenges as we were ramping up our vaccine sites and also our testing sites very early on in the pandemic and making sure that our access and functional needs community did have, again, access to those resources. In particular, one of the really strong partnerships that we had in Washington, D.C. was with Gallaudet University, which is one of the largest universities helping persons and people with who are deaf and hard of hearing, and communicating with them very early on and throughout the pandemic for their specific population allowed us to, I think, to implement a lot of lessons learned and make a lot of corrective actions that we just hadn't thought of at the beginning of the pandemic. Over time, we contracted for a lot of ASL interpreters and individuals who could be at the testing and the vaccination sites, so that we were making sure that we had the right resources there for that community, and so that really helped us, I think, deliver those critical services to some of our vulnerable populations, and in fact, I think one of the benefits that came out of all the experiences that we had throughout the pandemic is sort of cementing those relationships and making sure that as we go forward, and we are now bringing in FEMA, we're part of Region 3, to help us build lasting programs as we plan for the next pandemic and the next emergency, so that we are constantly implementing access and functional needs into our long-term planning and response documents. Thank you, Ron.
Thank you, Chris. Julie, from your role, what did you see as the challenges and any kind of lessons learned from large vaccine distribution?
Thanks. I was really impressed listening to the folks from California. We didn't have anything. We're just not as big in Colorado, and a lot of our state is rural. So what we did is in Colorado, there were some max vax sites, and many people with disabilities were served with them just fine. There are people with disabilities, many who drive and who can get into vehicles, who don't have a lot of these needs we're talking about. So I don't want to make it sound like people with disabilities were not served there. Those aren't the folks that call advocacy organizations, though. So we kind of address the issues where it's not working. And so the issues were, again, have already been discussed. For example, paratransit, where you have to be picked up at a certain time, and then in Colorado, you have to stay there an hour, which is kind of a problem, not just for the people, but for the sites, because they didn't want people sitting around. We didn't have that. I love what's in California. That would have made so much more sense. And people who just don't have transportation, who can't go to a drive-through thing. And then the other thing that we ran into were there was an order from our governor and maybe even federally that says do not check IDs, because that drives out people, particularly people from mixed status families. and that there were some places that were doing that. I think they were trying to deal with like where they could bill insurance. So I don't know that it was with any bad intent, but that was scaring certain populations off. Just addressing, like we heard those things, reporting it to the state, because people often will call us, not the government. But most of our solutions for this population were not in making those max vac sites accessible, but was other alternatives, which I know we're going to talk about in a minute. So I'll hold the rest till then.
Thank you, Julie. I appreciate that. So I'm going to actually run the next panel in a very similar order, running kind of federal government to state to local, down to the public, the private sector, and not-for-profit that Julie runs. So Roxy, can you now talk some about the mobile vaccines site, the mobile vaccine process, and challenges and lessons learned from that?
Absolutely. I'll try to save some this time. See, we did have a very robust mobile vaccination route. I'll start with our mega sites in California. So we had Oakland and we had Los Angeles. And from the start of the mega vaccination sites, it was clear to us that in order to truly reach the population, to reach the whole community, to reach a diverse group of individuals, we were going to need to take the show on the road. So out of Oakland and Los Angeles sites, there were 2 mobile vaccination routes per site that went to local organizations as coordinated through Cal OES and the organizations themselves. And the mobile routes were really the most effective way of reaching, again, that truly diverse population and meeting them on their terms and in their safe spaces as well. The organizations, which are trusted service providers or faith-based organizations in these communities, would host the mobile site and coordinate their patrons and the individuals that they serve to come and receive a vaccination, and then 3 weeks later, the second shot at the same location. The organizations were everything from churches and mosques and synagogues to disability organizations, independent living centers, organizations that serve specific community groups, senior centers, lots of different groups. So what made the mobile route so successful, I think, was really outreach to those community and advertising of the sites, working with these organizations and saying, how many individuals do you have? And if they didn't have, maybe it wasn't a huge organization, they might put a couple small organizations from the same community together into one space. And that was a really great way of, again, meeting people where they're at. For each of those mobile vaccination sites, every single site, both the first and the second time, because things change and the crews change. And we have that, this site is accessible because it's a parking lot, but does it stay accessible once we build it? Did we lay everything down in the accessible parking spots and set up all of our tents and not think about where people were going to be able to park to have access to that facility, things like that. So we did have disability integration out to review every single facility. They worked in coordination closely with Vance's team at Cal OES, with the logistics team, with the team that was building out the site, and with the civil rights advisors through FEMA. And they were able to kind of show in report form how the site should be set up. And then after it was built out, they would go to every single site on the opening day and ensure that those sites were built out in an accessible way. We also had the language interpreters. They would do the Cal OES, again, they were amazing with coordinating the language interpreters because that was a huge, huge job. They would do an assessment of the area and talk with the organizations that were hosting the mobile sites to ensure that they were providing the correct languages. I know there was confusion. I'll give an example. Once in Koreatown, they actually needed Spanish language interpreters in Koreatown, and that really threw people off for a minute. But having those local organizations and being able to partner with the local emergency managers, et cetera, kind of gave us the intel that we needed to make sure we were providing the right services in the right ways. So it was quite a mission. I also could touch on 2 rural routes in Nevada. Sometimes those routes, the locations they'd be doing the vaccinations at were 150 miles or more from any type of lodging or a grocery store even. And so these were truly rural routes, and they took a lot of work to make some of these sites accessible and to consider the impacts of working with a community that maybe lives that far out because they don't necessarily want to have the government in their backyard. And so kind of trying to build that trust level and work with those organizations. And there were also 2 mobile routes down in Tucson, very close to the border, and they had their own challenges in making sure that they were coordinating specifically with the county to provide those services in an accessible way. I'll pass it back. Thank you.
Yeah, so just to build on that from the state of California's perspective, working very, very closely with Roxy's team and Vance's team, every single new mobile site that we did had a pre-site visit to kind of understand and conceptualize what the layout was, how the flow was going to go, making sure that we had, accessible restrooms, hand washing stations, all that kind of stuff. Making sure that we had water and snacks. Sometimes these were hot. We had to get, make sure there's lots of tents. And these were probably, the large sites were complicated because the size and the sheer volume and all the different populations that you had to contend for. But they were, generally speaking, there, and you could iterate on them and improve as you went. The mobile sites were really like standing up a new small site every day and then breaking it down. And so there was a lot of logistical complexity with making sure that that went well and really, was accessible both on the language side as well as the access and functional needs side. And so a lot of pre-planning was required to make sure that happened smoothly. The main kind of point of partnering with all of these different non-governmental organizations, from churches to community groups, was really to get us out of the kind of large government run site. Some of the concerns that we had at the bigger ones, we had not armed, but military individuals, right? We had National Guard supporting us there and things like that, and really just the optics of making sure that we put those types of folks in different positions that were maybe not so customer facing for communities who had negative experiences in the past with military or law enforcement types, and being very conscious of the trauma in all these communities that we are trying our very, very best to serve was really important. So making sure that we're working with these community organizations as trusted messengers to reach these populations and do that in an accessible and efficient way was really, really critical. And so, lots of this stuff, I just can't say enough about Vance and Roxy's teams and how integral they were to making sure that our folks were thinking about all the angles and really, flagging challenges and concerns. And I'm just going to continue to beat that drum of deep integration, right, which I think is so critical to making these types of missions successful. That's it for me. Chris,
Ron,
over to you.
do you want me to? Yep. So hi, everyone. Chris Rodriguez again from DC. We obviously, we don't have the geographic footprint of the state of California. We're 62 square miles. So in terms of our mass vaccination sites, we only really had a handful across the city, but all of them, certainly when we stood them up with the DC Department of Health, very much, there's very much an attention to access and functional needs, making sure, for example, our signage, that we had interpreters at those facilities, and just accessibility for those individuals and communities. Again, I would say that, from our experience, having that integration very early on in the operational process as we're sort of conceiving of how we would deliver vaccinations was absolutely critical. And what we've done now, and kind of looking at a sustainable model for COVID vaccination sites, we've actually just created permanent sites across the city in each of our 8 wards. So 1 site per ward, 8 total, and those are also staffed with ASL interpreters. They are all accessible to some of our residents, again, who require or need those services. And I know that through the conceptual period of how to stand up what we call our COVID centers, again, our permanent COVID centers, there was a strong attention to making them all accessible. And so I think, that does provide a model for the city for future operations and future emergencies that we can continue to build on. I mean, did we do it all right the first time? No, and we still have to always improve on those processes. So, thank you, Ron.
So I'll speak more as those trusted community messengers, because that, as a advocacy group, we don't set up clinics. But what we did is try to work with the state and the people that did set up clinics to say what does and doesn't work. And so again, just like what I said earlier, certainly many people can just go get vaccines the way everyone else does, but there are people that can't or won't. And those are people, it was mentioned in the Q&As, that a lot of people with disabilities have huge distrust of the medical system, as well as distrust of government. So overcoming that was really important, making sure that people were going to be handled appropriately with kind of a trauma-informed response was important. So we did have we did a lot of pop-up equity clinics in Colorado, where there would be clinics geared for certain communities. And we did some disability-specific ones. We did some deaf ones. We did one at the Colorado Center for the Blind. We did them at different living centers. And those were very important, as well as community-specific education programs where people could ask and have, again, trusted messengers, along with some doctors and professionals that we chose because we felt like they could appropriately relate to our community, that would be on the panel with us to be able to answer our questions. That was really, really important. And also providing homebound vaccinations for people. And it wasn't just people that are literally homebound, but there are a lot of people for whom getting on a public bus was probably unsafe, especially for the first 2 vaccinations before there was any protection. And it worked. So with Colorado Medicaid, which is what most disabled people are on here, members with disabilities have a vaccination rate 22 points higher than members without disabilities. And homebound members who got the vaccines in their home have a vaccination rate 40 percentage points higher. We also did a lot of targeted outreach to communities of color, particularly we were involved in that in rural Colorado. And for Medicaid, this is not true for the whole state, but for Medicaid, members of color are vaccinated at a higher rate than white members. So what that says is that these targeted efforts work. And while it's really important to say whatever vaccination sites are done or whatever any program is done, it must be accessible. That's the law of the land. So I don't want anyone to take, oh, well, you're going to have these kind of pop-up clinics or equity clinics, that means that you don't have to be all inclusive with the typical ones, because you do. But for some populations, we are just more comfortable getting our services where we know we're not going to be mistreated and where we know that there are trusted messengers involved with the planning. So that's really what worked was having both of those options. And then, of course, having those of us who are advocates and trusted messengers be able to report, but not use some inbox or call some hotline that doesn't get answered, but that we could go directly to high up people in the state when there was a problem. So for example, we had a lot of problems with those sign up portals not being accessible. Or, we're hearing a certain Walgreens is asking for ID or whatever. When we could get those and we could go directly to a person, not some inbox or something anonymous, but a person, and get those things resolved or get questions answered, that was super, super important, is not only to resolve the problem, but to build trust. Because that says to our community that someone cares enough to listen and resolve a problem. We all knew there were going to be problems. The question is really, and how much do people care about resolving them?
All right, hey, Ron, I'm not sure if we still have you on or not, or if you dropped off. I know that the next part of the discussion and trying to wrap things up was going to focus on PPE and protective personal equipment, the way that that's being addressed. And Grady, why don't we kick you off on that? If you could start us off and just talk about, I think people want to know, one, how did you get PPE right at a time when none was available? What was the magic wand that you used to make that appear? And then maybe the process or steps you took to making sure that as it got prioritized, people with access with functional needs were put in the mix and things actually got to those individuals.
Absolutely. Thanks, Vance. So I think everybody's well aware of the kind of overall supply chain challenges that we've had with COVID-19, and that really began with personal protective equipment in the early days of the pandemic. And so, our director, Marco Laducci, was very aggressive and leaning forward to solve some of the big challenges that we saw coming down the pipeline. And so one of the first things we did was stood up a logistics and commodities task force that had a couple of missions. The first was to source and procure PPE. The second was to build a distribution network to be able to receive all of that PPE and ensure its quality. And then, finally making sure that we can distribute it to the communities in need through a prioritization system, because especially at the beginning, several months, there was not enough to go around. And so we really had a triage challenge on our hands there. So how do we solve the lack of PPE? We had an entire procurement arm that pulled together buyers from across the state government. We had about 40 people at our peak, doing nothing all day, every day, but making phone calls to different vendors and leads that were coming in from all over the place to try to achieve several different targets for PPE procurement. We continue to have challenges on masks for several months. And finally, we were able to strike a deal with BYD, which is a major electric vehicle manufacturer of all things in China. And they actually stood up an entire manufacturing line to begin to create high quality N95 and surgical masks, of which the state of California was one of the primary participants in that procurement, as well as Oregon, Washington, Texas, and several other states ended up doing some smaller contracts with them. But it really took us to kind of build it ourselves with some of those partners. And so, once we were receiving it, we had to make sure that we had the warehousing space. So we had kind of originally a very, very small warehouse footprint when we started COVID. We peaked at around 2.5 million square feet, which is, kind of not rivaling Amazon, but getting up there. And we had a mission to the team to do California Prime. So we wanted to be able to receive an order and deliver that order within 48 hours to make sure that the product was getting to where it needed early and often. And so once we had solved kind of the scarcity challenge, we began working with community organizations, specifically Vance's team, to make sure that we were reaching the AFN community more broadly, especially folks who are homebound or we're going to different locations around the state. And I think this is an area where policy matters, right? I mentioned previously that I came from FEMA, and so distant and headquarters in Region 9, working on recovery issues. So that team is near and dear to my heart. But the policy challenges that I think FEMA put in place, because it originally started very wide, and then in about September of 2020, they really narrowed the scope of what was eligible. And so the state of California, in many instances, had to make the decision to provide, lots and lots of product and forego reimbursement to some of the, most the communities that were most in need of this protective equipment. And so I think because of the narrowing of that policy to really apply primarily to clinical care delivery, hospitals and skilled nursing facilities as the primary, and then at one point education wasn't eligible. Many of the different communities that we work with in the AFN community were not eligible. California had to take the kind of affirmative stance that we would provide that, and regardless of reimbursement. So that was a policy area that I think could be improved upon in the future, to make that a little bit easier decision for more communities to be able to do. And we're fortunate in California that we had secured a good pipeline there, and we were able to do that. But really, it's just working very closely with Vance's team through that ordering process and making sure that we're understanding what the needs are, what those emerging challenges are, and ensuring that we've got the right dispatching policies in place to make sure that as those orders are coming in, they're not getting denied, and that they're getting out. And so, I think that's been a success, and we've also worked with public health to do that around testing and several other areas. And so, making sure that, regardless of the financials and things like that, at the end of the day, we want to do the right thing, and that's making sure that we are supporting communities who are most in need.
Thank you, Grady. Hopefully y'all can hear me again. I'm going to jump over to Dr. Rodriguez in DC. Chris, can you talk about your PPE distribution, and especially when you talk about the whole community?
Yeah, thanks, Ron. So much like California and Cal OES, we were very aggressive at the outset in getting PPE, and all of us can recall the challenges with getting gloves and masks early on in the pandemic. We also were, as I said, very aggressive in utilizing our emergency contracts to get PPE. And again, in some respects, we were fortunate by sort of our geographical areas, and so we were able to directly provide PPE to our residents very quickly in a variety of distribution centers across the city. Also, and also in communities where we did assess the need for access and functional needs and persons with disabilities. So we did provide sort of that supply chain. We also, much like Grady just mentioned, had to establish a disaster warehouse for putting all of those PPE supplies in and then distributing them to different parts of the city. So we also, in many cases, had areas where not only were we actively distributing, but we were also inviting people to come and just pick up what we called like sort of care boxes that had a variety of PPE, hand sanitizer, masks, gloves, for all of our residents. And at those sites did have, as I mentioned, interpreters and individuals who could assist persons with disabilities to make sure that they were getting exactly what they needed and when they needed it. So again, sort of benefiting from our size, but we could, in many respects, distribute directly to our residents throughout the early days of the pandemic. Thank you, Ron.
Thank you, Chris. And Julie, I'm going to jump to you because obviously your stakeholders, your very unique stakeholder base, and I'd be interested to hear more about your PPE distribution challenges and lessons learned.
Yeah, it was pretty confusing and frustrating, particularly for people that had home care aides that needed to be able to provide it for them. but because most of us in Colorado, with at least with significant disabilities, employ our people directly. So and the system didn't understand that there wasn't some agency that could give them, that we needed to get them directly. And for people who, again, so for the first challenge was, it was up to each county to distribute, and some did and some didn't. The second was a communication issue where the emergency preparedness people were saying, well, you go through your county department. Well, in our world, the county department is not a county public health department. Most of us didn't even know who those were or what they were. It's county human services. So people were calling county human services saying the state said that we can get PPE here, and they didn't know what we were talking about. And it actually took a couple of weeks for us to figure out what the disconnect was, because people kept coming back to us and saying, no, they don't have anything. They're, they don't know what we're talking about. And that's because one state agency was talking about the county departments, but that's not the system that we're used to dealing with. In a few rural areas, they're one and the same, but in most of the areas, they're not one and the same. And then for people that had to pick them up, again, for people that couldn't, that don't have a way to get somewhere, that was a challenge. Then as it became more available, there are just these huge amounts of PPE that were kind of being like thrown at people. So I know at one point, like hundreds of boxes of gloves appeared at our office. Again, we're not a service provider, we're an advocacy organization. Or like we get like boxes of homemade masks, and so I think that then it was like, so how do we distribute this? We're not set up to do that, and we did the best we could. I still think we have boxes and boxes of gloves in our office. So it was pretty chaotic. And then the biggest thing that I think didn't really get solved as it became more available, I think people just eventually figured it out. Some people in some counties were able to go get it, and they got a whole bunch of stuff, and it was great. It was just very mixed around the state. Was the clear masks. There was no one that took responsibility to say, either to say to the counties that were buying it, you have to include this. There was some people were saying, well, the independent living centers got money, they should buy it. The independent living centers were saying, no, it's not our job. So that never really happened. It's only been recently, in like the past 6 months, that some of our larger hospital systems have started providing those. But that's been a huge struggle, and also kind of a logistical issue, because then the people that need them, like the people who are deaf or hard of hearing, are getting them, but that didn't help them when they were like trying to talk to a clerk at a store or a bank teller or other people, because they really need to be everywhere for it to work, and they're all more expensive. So that's just been a challenge that we've not figured out. Of course, people aren't using masks anymore, so but if we ever get in a situation where masks are needed again, I think that's something that really needs to be figured out. And so I think the lesson learned is, that's why I think people need to be involved at all levels, just to understand things like, what State Department are you talking about, or giving a list with names and numbers, not just links to some county, because there are different departments in a county. So for people to understand where they're supposed to go, and then also for the systems to understand our systems, so that they understand that, again, most of us don't use home health agencies. So just saying your home health agency is supposed to provide it is meaningless to a lot of us. So those are just some of the lessons learned. And again, that all comes down to having the right people at the table. But of course, because emergency preparedness is not our business, and when there's not a disaster, there's no funding, we're not going to be at those meetings really until there's a disaster, unless someone provides funding for that. So that's again, one of those challenges. There's only so much planning you can do when there's not an emergency.
Good point, Julie. Roxy, you want to weigh in on this PPE distribution conversation?
I feel like everybody pretty well touched on it. I think something really important that maybe we haven't touched on fully yet is really engaging with community partners and making sure that we're communicating with organizations that serve individuals with disabilities to find out and understand better what their needs are. Julie touched on that, specifically talking about how we didn't end up coming to a solution with clear masks. But it really we had to do a significant amount of engagement with community partners. And I know that Vance's team did as well, getting on calls with organizations that serve individuals with disabilities and finding out what it is that they were missing to be able to feel safe and to be able to participate in vaccination and in everyday life. Did they need PPE? What types of things were missing for them to feel safe and comfortable coming to the vaccination sites? Was that a PPE issue, or were there other issues involved? Were they waiting till they could receive services at home or at a doctor's office? What did that look like? And so I think, just at the end here, making sure to say no one organization, no one group, no one person can be fully aware of every issue that we might encounter, or every challenge that we might face, or every positive thing that we might need to do. And in discussing these actions with our community partners, I had a wonderful conversation with June Kales before the vaccination sites were set up, and she really touched on the paratransit issues. And we were able to take that and put it for action and make that a successful piece of that vaccination site. And the same goes with PPE. I think that when we found out what people were missing and how we could meet them where they needed to be met, we were always more successful. So, engaging with community partners and planning with people and not for people is really the key.
Thank you, Roxy. So we do have a few minutes left, and I'm going to conclude at the end with kind of just closing remarks by each of the panelists. But I'm going to jump to one of the questions that's posed in the Q&A, try to get to at least one of these. And I'm going to start with Grady. There's a question, I think Julie touched on this, but it says, I would love it if the speakers could share how PPE has been distributed in their area to people who utilize home and community-based services, as well as their personal assistants / direct support professionals. Can you talk to how California has done this at all? And then I'll go to Dr. Rodriguez with the same question.
Yeah, certainly. So I think COVID and certainly the logistics response to COVID, it overwhelmed all of our normal distribution channels. So California and Cal OES in particular, we are generally optimized and organized to provide support to county governments, and then county governments provide that direct support to their residents who have been impacted. And so the main two channels that we use for that would be the Offices of Emergency Management in a county or public health. And both of those entities in COVID were, obviously overwhelmed with just the sheer magnitude of operational logistical challenges that they had to respond to. And so we had to think through ways that we could, because we're not structured to, provide kind of an Amazon, like a direct customer facing interface to order small amounts of things. And so we really had to focus on partnering with community-based organizations who could, get out to the community. Folks with home healthcare aides being part of that, but we had to do this in a whole, bunch of different verticals. But really find those local organizations that can pool needs together, receive larger quantities of PPE and commodities from us, and then help us with that last mile distribution. And so just really working closely with Vance's team to identify those groups geographically. We tried to find at least one in every county. If it's more, if it's denser populated or more sparsely populated where the travel times are longer. And really just trying to focus on getting as close as possible to folks. But we really, unfortunately, just don't have the resources from a personnel perspective to deal with millions of orders. We shipped throughout the pandemic about 1.67 billion units of PPE throughout California. But in order to do that type of volume with the team that we have and the resources that we have, it really focuses on larger quantities to sub-entities, community-based organizations generally, or different associations who then helped us with that last mile distribution. And there was a number of non-governmental organizations that we worked with in different areas of the state to be able to meet that mission and support those communities that were not able to be supported by the the traditional county government entities that we would look to for these types of things.
Thank you, Grady. Chris, you all in DC, were you able to find any innovative ways to distribute PPE to those who utilize home and community-based services?
Yeah, thanks, Ron. So, since the beginning of the pandemic, we've really focused, as I'm sure a lot of other jurisdictions did, on looking at our most vulnerable residents, particularly in our long-term care facilities, both public and private, those run by Department of Human Services, our Department of Health, our Department of Behavioral Health as well. And so working with those departments to send through our logistics supply chain the PPE to those facilities. And then largely those facilities would have their own distribution processes in place throughout those facilities to make sure that the PPE was getting to where it needed to be to those residents. We also worked very closely with our private providers for our long-term healthcare facilities to distribute that PPE. A lot of it from the response side and logistics side was just getting the PPE to those locations so they could be distributed by those the owners and operators of those facilities. So for the most part, it worked fairly well and helped to contain the virus in those vulnerable populations, and to the point where we didn't really see a lot of major outbreaks in our long-term care facilities. Thank you.
Thank you, Chris. So to all the panelists, I'm going to ask one last concluding question. So hopefully we have time to get through this, but as briefly as you can, what's the one thing you want all of the attendees to remember about this conversation we've had today? I'm going to start with Julie. What's the one thing you want all the attendees to remember?
That people from the disability community have a lot to offer. It's not just about what we need, but it's about the resilience and strength and ideas that we have that can really help everyone. So I think keep that in mind, because we can be very, very helpful. When the pandemic started, we're the community of people that, a lot of us have had experience like, being in bed for a year or going into sudden poverty or having to deal with very sudden life changes. So we're the people that know how to do this on a personal level, use that expertise to help make better decisions for everyone, and work with us, see us as a resource. And again, involve us, but also understand that, if it's a significant amount of time, there has to be funding that goes with that. But there are plenty of good people out there that you hire us on your own staffs. That's, I think, what I want you to do.
Thank you, Julie. Grady, how about you? What's your recommendation? What's the one thing you want everybody to remember about this?
I think just going back to the point of planning with the AFN community as opposed to planning for the AFN community, and making sure that your logistics and operations teams have that really, really tight integration from day one at the ground floor level, and making sure that you're working, with the folks who are going to be most impacted by the different, operational decisions that you're making, and continuously iterating, right? Making sure that you have a culture within your teams and within your staff of always wanting to find the challenge, find the issue, and fix it as quickly as humanly possible. We can never plan for every challenge or every issue that will arise, but if you have that culture of find it and fix it as quickly as humanly possible, I think we can continue to make progress and continue to support the whole community in these responses and recoveries.
Thank you, Grady. Roxy, how about you?
Hey, I think it's beyond important to take the lessons learned and move forward better. Now that we know better, we should do better. We don't need to continue making the same mistakes. Work with disability organizations in meaningful ways. They're not just there to play victims, like Julie said, or to help when you need it, because when you need a friend, it's too late to make one. Having solid relationships with disability organizations that's honest, where you ask honest questions, you provide honest feedback, and you take feedback and you make changes with it. Those are the most important things to take forward, in my opinion. Grady said it as well. Work with your disability organizations to plan with, not for, people with disabilities.
Awesome. I like the with, not for. Chris, how about you? What's the one thing you want all the attendees to walk away remembering?
Yeah, all great answers from all the panelists. I would say that the disability community and organizations make us better emergency managers, right? The more that we can engage in these discussions, and the community, we have a very active community in the District of Columbia, and that's a good thing, because we want to make sure that we are continuing to serve all of our whole community, and just keep pushing the envelope together and making sure, again, as Roxy said, like just making sure that we're planning with, not for.
All right. Well, panelists, thank you for your time today. It's been great. I've really enjoyed it, and I'm going to turn it back over to Vance. Vance, it's all yours.
All right, thank you. This was fantastic. I absolutely appreciate a spectacular day one. I want to thank panel number one, talking about the trifecta there, the way partnership matters. I want to thank the second panel for talking about PPE and all the great things going on in terms of COVID that are innovative and new and have never been done before.